Good evening, all. Today's we have a discussion GTG number 61, that is sickle cell disease in pregnancy. Okay, so there are two things. One is a sickle cell disease, second is a thalassemia. So in sickle cell disease, the problem is a sickling. It presents as acute episodic and vaso-occlusive condition, while in thalassemia there is a production or the hemoglobin is defective, so it presents as a chronic requires a chronic it's a chronic condition, requires transfusion, and there is a iron overload. So that is what is the clinical picture and the pathophysiology in these two conditions. Okay, so core clinical difference is that sickle cell disease will present as a pain, crisis, and acute complications, while thalassemia will present as anemia, transfusion, iron overload, etc. Okay, so when we manage sickle cell disease from management point of view, we need to ask, is there a crisis? Is there a acute chest syndrome? And do I need to go for exchange transfusion in sickle cell disease? Okay, so the focus is management of the acute emergency. That is how we should think when there is a sickle cell disease, or if there is acute presentation, we will think in terms of sickle cell disease. Okay, while in thalassemia, we are always thinking, is the hemoglobin adequate? What is the iron load? Is the heart safe? And this is a chronic condition, so chronic optimization is required in thalassemia. Okay, so in sickle cell disease, it is transfusion in sickle cell disease is mainly for acute conditions like acute anemia, then acute chest syndrome, where the exchange transfusion is required. In acute stroke also, exchange transfusion is required. In acute anemia, top up transfusion is required. Okay, so remember, exchange transfusion where it is required: acute chest syndrome and acute stroke, exchange transfusion. Okay, so thalassemia, blood transfusion is interruption. So thalassemia blood transfusion is routine maintenance, and it suppresses. Goal is to suppress the ineffective erythropoiesis. So the patient will be lifelong dependent on the blood transfusion. Okay. So sickle cell disease is autosomal recessive disorder. It is caused by the abnormal hemoglobin, that is a sickle hemoglobin, and it includes HBSS, that is sickle cell anemia, HBSC, HBS plus beta thalassemia, HBS plus D, E, or O Arab hemoglobin. Okay. Then we have a sickle cell trait, that is HBAS. Usually these patients are asymptomatic, and that is not included in this guideline discussion. Okay, so we will cover mainly the HBS. Okay, HBSS. So this disease is very common in sub-Saharan Africa, Middle East, India, Mediterranean region, Caribbean region, etc. Okay. Then what is the pathophysiology in sickle cell disease? It is because of the low oxygen. There is a decrease in HBS polymerization. There is a HBS polymerization that leads to the RBS sickling, RBC sickling, and because of the rigid cells, that leads to the hemolysis, leading to anemia and vaso-occlusive crisis. So when there is a low oxygen tension, there is a polymerization of this HBS that leads to the sickling of the RBCs. Okay, and leading to the hemolysis. That is what is the pathophysiology. So complications of sickle cell disease will include in acute conditions, there will be painful crisis, acute chest syndrome, while in chronic, there will be stroke, pulmonary hypertension, renal disease, retinopathy, avascular necrosis, and the gallstones. So what are the risks during the pregnancy? The maternal risk will be painful crisis, very common. Acute chest syndrome can happen. Infection chances are increased. Thromboembolism, preeclampsia risk is high, and maternal mortality is increased. While in fetus, FGR risk, preterm birth, perinatal mortality is increased, fetal distress, increased cesarean section rate, and miscarriage. So in this sickle cell disease, preconception counseling is very, very important. So early counseling plus embryo care is important here, and there has to be annual specialist review. So what are the points which are important from counseling point of view? We need to counsel that dehydration, cold, hypoxia, stress, that is to be avoided. These are the trigger factors for the crisis. Okay, sickling crisis can be there because of the dehydration, cold, hypoxia, and stress. So pregnancy risk, there is increased risk of anemia, increased crisis, increased infection, especially urinary tract infection is common, and increased acute chest syndrome. So do remember that chances of urinary tract infection are very high in patients with sickle cell disease. Okay, may be important from SBA point of view. Fetal risk, FGR risk is increased, and also there is increased interventions such as induction and cesarean section. Okay, so there is also a risk of transmission to the baby. So baby may be affected. So preconception assessment will be cardiac assessment, cardiography, and look for any pulmonary hypertension. Renal screening will be done by blood pressure and urine analysis. For liver, we do LFTs. For eye, retinal screening is required. Iron, ferritin plus MRI, T2 MRI. And, for immunological condition, look for red cell antibodies. So these are the things which we need to look for. ECG, then echocardiography, blood pressure and analysis, urine analysis, LFTs, retinal screening is important. Iron stores we need to look for, iron deposition and red cell antibodies. Then coming to the pulmonary hypertension, screening is done by the echocardiography, and risk marker is a tricuspid regurgitation jet velocity more than 2.5 millisecond m per second. Okay, so that is what is the trigger factor. So you should remember this jet velocity. Okay. So general preconception measure, vaccination advice, medication review, crisis prevention strategies, and low threshold for hospital visit. Okay. So genetic screening, we need to test the partner. So test the partner for hemoglobinopathy. If both are at risk, offer genetic counseling, prenatal diagnosis, and discuss termination and pre-implantation genetic diagnosis. If the partner risk, if the partner is unknown, or if the partner status is unknown, treat that the fetus is at high risk. Okay, so then if both are carriers, in that particular case, genetic counseling plus prenatal genetic diagnosis is required. So this is what is given in the chart. So conditions requiring counseling when the mother is affected by sickle cell disease. So mother is affected by sickle cell disease and the status of the partner is either HBS or beta thalassemia or O Arab or HBC or D Punjab. That means it is high risk. Okay. While if the status of the partner is HBE, leopard, or hereditary persistence of fetal hemoglobin, then it is a moderate risk. Okay. So if it is a moderate risk, then we have to individualize the case and accordingly we have to treat. While if it is a high risk, then we have to offer them the prenatal genetic diagnosis. The same thing is given here. So first thing what we will do, we'll test the partner for hemoglobinopathy status. If the partner is normal, that is HbA status, then it is a low risk, and we will that means the fetus will be carrier only, and we will just reassure and no prenatal diagnosis will be required. However, if the partner is having the disease or is a carrier, then identify the type of hemoglobinopathy. If there is a high risk combination such as HBS, HBC, beta thal, O Arab or D, in that particular case, we'll refer to the genetic counseling, and we will also offer the prenatal diagnosis such as CVS and amniocentesis and discuss the termination option plus reproductive option. While if it is a moderate or uncertain, such as HBE, leopard, or HPFH, that is hereditary persistence of fetal hemoglobin, then we will further investigate by HB electrophoresis or DNA studies, and we will individualize the case and decide the prenatal diagnosis. So here it is a prenatal diagnosis will be individualized, while in these cases where there is HB partner status is HBS, HBC, beta thal, then genetic counseling is must. So from EMK point of view, you should remember when the mother is having sickle cell disease and the partner status is normal, then we can go ahead with reassurance. No prenatal diagnosis is required. If the partner status is high risk category, that is HBS, HBC, beta thal, we will advise them the genetic counseling plus prenatal diagnosis. Okay, and here in moderate cases, it is an individualization of the case. So in special situation, if the partner is not tested or partner is not known, then we have to treat this as a high risk and offer the prenatal diagnosis. So this is the thing which we need to learn here. Okay. Then coming to the antibiotic prophylaxis and immunization. So sickle cell disease, there is a functional hyposplenism. There is increased risk of encapsulated organism. So Streptococcus pneumoniae, Neisseria meningitis, and H. influenzae. So these infections are common. So penicillin is required daily. Then if there is an allergy, then we'll go for erythromycin. So evidence is strong in children. Practice extended to adults and pregnancy. Okay. Vaccinations. Pneumococcal every 5 years, meningococcal C single dose, H. influenza type B single dose. This we have seen in the thalassemia also. Hepatitis B, check the status, and if negative, then we'll go for vaccination. While influenza vaccine will be required annually. Okay, live vaccines are to be avoided during the pregnancy. That care we need to take. Coming to the vitamin supplementation, high dose of folic acid, there is 5 milligram per day will be required. Pre-conception plus throughout pregnancy, we need to give folic acid. So this is mainly because the chronic hemolysis is going on and there is an increased folate demand. Okay. It also prevents the neural tube defects. So pre-conception, we need to stop certain drugs like hydroxycarbamide, that is teratogenic, AC inhibitors, that is phytotoxic, ARBs, phytotoxic. So drug history in pre-conception counseling is very, very important. Then hydroxycarbamide, we need to stop at least 3 months before conception. If the pregnancy occurs, we need to stop immediately and do detailed anomaly scan. And we might termination is not indicated solely just because of the exposure. So if there is only exposure, then that is not the sole indication for the termination. We need to stop it immediately. Okay. Coming to the antenatal care, so it is always a multidisciplinary team care with obstetrician, hematologist, and specialist midwife. The crisis prevention is the aim. So avoid dehydration, cold exposure, or exertion. If there is a persistent vomiting, early admission will be indicated. Okay. If no preconception care taken, do as early as possible vaccination review, iron status, and antibody screening. Antenatal hemoglobinopathy screening, if not done earlier, then test partner as early as possible. If partner is a carrier, then counsel before 10 weeks of gestation and offer prenatal diagnosis by CVS. Okay. So if the partner testing is not done preconceptionally, we will do it as early as possible. And if the partner is a carrier, then go for prenatal diagnosis by CVS. Okay. So early diagnosis allows termination option. Okay. So drugs during the pregnancy will continue with folic acid, penicillin to be continued, iron only if there is a deficiency which is proven. Okay. Aspirin 75 milligram to be started from 12-week onwards up to 28 weeks. Okay. LMWH will be given during hospital admission and NSAID is only 12 to 28 weeks. Okay. Aspirin will be started from 12-week onwards, not till 28. It will be continued. Okay. While NSAID is between 12 to 28 because in the third trimester, we don't give NSAIDs. Okay. Sickle cell disease, there is a moderate risk for preeclampsia, so give aspirin. Iron overload is common, so avoid routine iron. Antenatally, in each visit, we have to check the blood pressure and do the urine analysis. Watch for preeclampsia and proteinuria. Infection surveillance, monthly we will do the urine culture. Important thing in sickle cell disease, patients may have low baseline blood pressure. Even small increase in the blood pressure is very significant in these patients with sickle cell disease. Okay. Ultrasound schedule is like any other routine patients. Viability scan around 7 to 9 weeks, NT scan 11 to 14 weeks, anomaly scan 20 weeks, and growth scan will be important for these patients. It will be started every 4 weekly from 24 weeks of gestation because there is a risk of FGR and preeclampsia. Blood transfusion in pregnancy, not routinely recommended. So when to go for blood transfusion? If there is acute complications such as acute chest syndrome. So sickle cell disease, we give blood transfusion only in acute emergencies like acute chest syndrome. Okay. So the blood should be properly matched. There should be extended matching for the RH as well as keel blood group is to be done and the blood should be CMV negative. Okay. So why avoid routine transfusion? Because there is a risk of alloimmunization, iron overload, and transfusion reaction. Okay. So this is the antenatal protocol that we have already discussed. What when to do the scan? Okay, up to 28 weeks, 4 weekly, and after that the patient will require 2 weekly visits. Okay. So what is the role of top-up transfusion? It is done in acute anemia, while exchange transfusion will be required in cases of acute chest syndrome and acute stroke. There it is the exchange transfusion, while top-up transfusion will be required in acute anemia. Okay. Indications will be acute anemia, aplastic crisis, splenic sequestration, and this increased hemolysis. Threshold is if the hemoglobin is less than 6 gram per deciliter or if there is a fall in hemoglobin by more than 2, then we go for the top-up transfusion. Okay. Now is the acute exchange transfusion. Exchange transfusion will be indicated in 2 cases. One is acute chest syndrome and second is acute stroke. Okay. So it is a multidisciplinary team management. Hematologist plus obstetrician is involved. Continue transfusion if the patient is already on the regimen for stroke prevention. Okay. So acute anemia, it is a top-up transfusion. Acute chest syndrome, exchange transfusion. Acute stroke, exchange transfusion. Previous severe complications, the case is to be individualized. Already the patient is on transfusion program, we will continue the transfusion during pregnancy. If it is a twin pregnancy, we may consider prophylactic transfusion. Okay. Coming to the status of alloimmunization, because these patients are likely to have antibodies. Okay. So this incidence is around 18 to 36%. This figure you can remember, the percentage of antibodies in patients with sickle cell disease is 18 to 36%. And this leads to the delayed hemolytic reactions, hemolytic disease of the newborn, and difficulty in future transfusion. Okay, so prevention, you have to match the blood for other blood groups also, as C, E, means D, as well as kill antigens. You need to do the cross matching. Okay, so how to manage the acute painful crisis? This is seen in around 27 to 50% of pregnancy. Most common cause of admission. So initial on admission, we have to exclude the complications first, such as acute chest syndrome, sepsis, dehydration. Okay. Management is a stepwise management. You rapidly assess, give the pain relief. Okay. Look for infection, assess the vital parameters, check FBC, reticulocyte count, renal function, chest X-ray, cultures, LFT, that is to be done. And analgesia, WHO ladder will be followed. In mild cases, it is paracetamol. In moderate cases, weak opioid. In severe cases, it will be strong opioids like morphine will be required. The most important thing is that you have to avoid pethidine. This is very important because it has got a seizure risk. Okay, so sickle cell disease, avoid pethidine because it is a epileptogenic or it increases the seizure risk. Okay, so analgesia should be provided within 30 minutes of admission and pain should be controlled within 1 hour. So when the patient comes in crisis, this is the thing which you should remember. Give first the analgesia. Okay, for analgesia, follow the WHO ladder. Mild paracetamol will give first. If it is a moderate to severe pain, we'll go for opioids. Okay. Then supportive care, the fluid requirement is around 60 ml per kg per day. If SpO2 is less than 95%, then give oxygen. Other measures such as thromboprophylaxis by LMWH will be started. Treat infection and antiemetics, laxative, etc. And we will continue monitoring. Okay, so that is how the acute crisis is managed. Other condition like acute chest syndrome, which is life threatening, that will be presenting as a chest pain, fever, cough, hypoxia, and chest X-ray will show new infiltrate. Management is with oxygen, IV antibiotic, top up transfusion, and main is the exchange transfusion even here. Okay, so treat as a pneumonia plus acute chest syndrome. So clinically here, this is a EMQ type of question. They'll give you the known case of sickle cell disease and she will presenting with chest pain and they'll give you the X-ray picture also mentioning that there are new infiltrate. Then the diagnosis is a acute chest syndrome. Okay. And the treatment is a exchange transfusion here. Okay. So this practically to be treated as a pneumonia plus acute chest syndrome. Early ICU admission is required. Next complication is a pulmonary embolism. There is a high risk for the sickle cell disease patients to develop pulmonary embolism. If suspected, start therapeutic low molecular weight heparin immediately. Acute stroke is a medical emergency. There will be neurological deficit and patient will require urgent brain imaging and exchange transfusion. Okay, here thrombolysis is not indicated. Next is acute anemia. Acute anemia may be because of aplastic crisis, hemolysis, and bleeding. Okay, this aplastic crisis, which organism or which virus is involved? It is a parvovirus or erythrovirus, which is same. Okay, do remember this is a SBA question. Parvovirus or erythrovirus will cause acute anemia in patients with sickle cell disease. Okay, so key investigation will be reticulocyte count. It will be low. That will be suggestive of aplastic crisis. Okay, management is by blood transfusion, and if the virus, isolation will be required. Fetal risk is a hydrops fetalis. We need to refer the case to the fetal medicine specialist. Other rare causes, there can be splenic sequestration, malaria. It is important in endemic cases. So timing of the delivery, elective delivery around 38 weeks of gestation, either by induction or cesarean section. Okay, so it is the safe confinement is required around 38 weeks of gestation. Mode of delivery is vaginal delivery. sickle cell disease is not a contraindication for vaginal delivery. Even the VBAC patient can have the VBAC also. So if the scenario mentions that the patient is sickle cell disease and she is a case of previous LACS satisfying the criteria for VBAC, VBAC is permitted. Okay. So coming to the blood preparation, if there are atypical antibodies, we need to cross match the blood. If there are no antibodies, just group and save. Okay. If the mother has having hip replacement because of the avascular necrosis of the femur, head of the femur, then we might have to get orthopedic opinion done because she might have the difficulty in giving the position. Okay. Or we might have to think of the alternative positions. Okay. Then place and setup, it will be always in the tertiary care center. Delivery will be planned and multidisciplinary team consisting of obstetrician, anesthetist, hematologist, and senior midwife will be required. Intrapartum, the patient needs to be maintained warm, well hydrated. CTG will be continued. Oral fluid is preferred, but if the patient is not taking orally, IV fluid will be given. Strict IVO chart is to be maintained. Oxygen, if the oxygen saturation ABG is suggestive of hypoxia, SpO2 is less than 94%, oxygen and ABG will be required. Infection, no routine antibiotics, but if there is a fever more than 37.5 degrees centigrade, we need to investigate, and there is a low threshold to start the antibiotics in patients with sickle cell disease. Then coming to the labor. Okay, if the labor is prolonged more than 12 hours, there is increased risk of crisis due to the dehydration. So if there is a good progress, we will continue with the labor. If there is a poor progress of labor, then we will consider the LSCS. So prolongation of the labor is to be avoided. Dehydration is to be avoided because it is a risk of sickle cell crisis. Okay. So analgesia and anesthesia, avoid pethidine. That is the most important thing. Then safe options, other opioids, epidural can be given. Then anesthesia for LSCS, regional is preferred. Avoid general anesthesia as far as possible. Okay. Anesthetic review, you can get it done antenatally. If there is a crisis in labor, manage same as antenatal crisis, which we have already discussed. And intrapartum, what we need to remember, delivery at around 38 weeks of gestation. Vaginal delivery is preferred. CTG will be continuous. Maintain hydration, oxygenation, and avoid pethidine. Regional anesthesia is better than the general anesthesia. Then postpartum care, neonatal care, higher risk baby, we need to screen the baby for sickle cell disease and send it to the specialized lab. Maternal care, maintain SpO2 more than 94% and adequate hydration will be maintained. Sickle cell crisis risk is there around 25%. So 1 in 4 can have postpartum sickle cell crisis. Okay. So general measures will be early ambulation and continue with vigilance. Thromboprophylaxis, if the lady is delivered vaginally, we will give thromboprophylaxis during admission plus 7 days. And if she is delivered by cesarean section, then it is for 6 weeks. Okay, along with anti-embolic stockings. Then analgesia, NSAIDs are safe, opiates are safe. Okay, breastfeeding will be encouraged and it is safe in sickle cell disease. Contraceptive. Okay, in sickle cell disease, progesterone only pill, DMPA, Depo-Provera, and LNG-IUS. All progesterone contraceptives are safe. This is also SBA, either from FSRH point of view or from this maternal medicine point of view. There can be question anywhere that the sickle cell disease, the preferred contraceptive. Okay, mainly it is the DMPA which is safe because it reduces the sickling crisis also. Okay, second line is the oral contraceptive pills containing the estrogen. While we have seen that in thalassemia, OC pill also is a first line. While in sickle cell disease, it is the progesterone pills, DMPA and LNGIUS. Okay, so in sickle cell disease, it is a second line COCP because it increases the VTE risk. Other barrier methods are safe. Emergency contraception are safe. Okay, so from examination point of view, progesterone methods are preferred. DMPA decreases the painful crisis, and COCP is the second line contraceptive. Okay, so difference between the thalassemia and sickle cell disease. Which disease has got a pain crisis? It is a sickle cell disease. Which disease gives iron overload and cardiomyopathy? Thalassemia. Which needs routine transfusion? Thalassemia. Which needs exchange transfusion in emergency? It is sickle cell disease. Okay. So HBAS is not clinically significant. HBSS is the most severe form which we have discussed. Then crisis triggers are the dehydration, hypoxia. Okay. Then Tricuspid regurgitation velocity of more than 2.5 m per second is an indication for pulmonary hypertension risk. Partner testing is mandatory before pregnancy. If the partner is unknown, then treat the fetus is at high risk. If there is FGR plus crisis, hallmark of pregnancy complications, penicillin prophylaxis is given to all sickle cell patients. Encapsulated organisms, that is the key infection risk. Folic acid 5 milligram per day. Hydroxyurea needs to be stopped 3 months before. Aspirin to be started at 12 weeks. Iron only if it is deficient, otherwise don't give iron. Growth scan 4 weekly from 24 weeks. Routine transfusion is not required in sickle cell disease. LMWH during hospital admission. If HB is 6 or there is a decreased hemoglobin less than 2, then go for transfusion. Acute chest syndrome, go for exchange transfusion. Stroke, go for exchange transfusion. Pethidine is contraindicated in sickle cell disease. Analgesia to be given within 30 minutes. Pain crisis is the most common complication, and reticulocytopenia is suggestive of a plastic crisis. Okay, so sickle cell disease plus hypoxia, we will think of acute chest syndrome, pulmonary embolism, uh, then delivery is at around 38 weeks. Okay, mode is the vaginal delivery which is preferred. Then CTG, continuous CTG in the labor, avoid pethidine. Okay, so this also duration of thromboprophylaxis for vaginal delivery 7 days and LSS 6 weeks. So that we have seen. Postpartum crisis risk is 25%. That is 1 in 4. Progesterone contraception are the best choices. Okay, so that finishes the sickle cell disease in pregnancy GTG number 67. Okay, so 61 number GTG is over. Thank you. We have few questions, doctor. Will you please go through the questions?
A woman with HBSS marries a man with sickle cell trait HBAS. What is the risk of the fetus having SCD? So it is A 25%.
Why 25%, doctor? He is a carrier, no? Mother is affected and partner is a carrier. So it should be 50%. If both are carrier,
50% way.
if both are
Hmm.
carrier, in that
Hmm.
case it will be 25%.
Okay,
It is a
okay. One is
it is
affected, yes.
when she is affected, lady is affected, and husband is a carrier. Okay,
Hmm.
got it. So it is 50%. Okay. So mother is HBSS. Always give HBS. Father is HBAS. So there is a everything will depend upon the partner's race because mother is affected. She is homozygous. Okay. So it will be 50% HBS and 50% HBA. Okay. So 50% offsprings will be affected. Next.
A pregnant woman with sickle cell disease presents at 9 weeks. Her partner is unavailable for testing. What is the next best step? So in this case, we have to offer prenatal diagnosis.
Yes. So dictum is that offer prenatal diagnosis. Consider that the baby is likely to get
Considering
affected.
fetus at high risk,
High
we
risk,
will
yeah, will go
yes.
for offer prenatal diagnosis. Okay, unknown partner treat as fetus is at high risk. Next.
A pregnant woman with sickle cell disease presents with hemoglobin 5.8 gram per deciliter and fatigue. What is the most common appropriate management? So here she needs B top up transfusion.
Yes, because it is a acute anemia. Okay, so acute anemia, it
Yes.
is a top up transfusion. HB less than 6 gram per top up transfusion. Exchange is reserved for ACS and stroke. Next.
A pregnant woman with sickle cell disease presents with chest pain, hypoxia, and chest X-ray shows infiltrates. What is the definitive management? So, in this case, A antibiotics, oxygen, exchange, A or B? I think oxygen supply.
Oh, it is exchange transfusion. They want the definitive management, no?
Is it acute chest syndrome?
Yes, acute chest syndrome. New
Then it is
infiltrates at
exchange transfusion.
transfusion. Yeah,
Yes.
it's a exchange transfusion. Okay, ACS requires exchange transfusion. Next,
Pregnant woman develops acute hemiparesis. What is the most appropriate management? Again, it is C, exchange transfusion.
yeah, it is acute stroke.
For
Okay,
ACS and stroke, it is exchange transfusion.
yes. Next,
Which drug should be avoided in sickle cell painful crisis? It is pethidine because it can cause seizures.
yeah, epileptogenic. Okay, next,
Which medication should be routinely given from 12 weeks? So it is aspirin because these SCD patients are more prone to develop preeclampsia.
preeclampsia. Correct.
Which is the most appropriate intrapartum management? It is C, continuous CTG.
Yes, continuous CTG. Impairs fetal distress, continuous CTG.
Which is the most appropriate postpartum contraception? So in SCT, it is a progesterone only pill, and
Yeah,
out of these progesterone, DMPA is the ideal
it's yeah better if you have
because
the
it
option,
decreases
then
the sickle
crisis.
cell crisis and pain.
Okay, we have few EMQ also, doctor. Mm,
A
yes,
28-year-old woman at 30 weeks presents with fever, chest pain, hypoxia, and chest infiltrates. So here the option is B, exchange transfusion.
yes. Next,
A 26-year-old woman presents with sudden right-sided weakness. Again, the answer is exchange transfusion.
yes. Here urgent brain
Urgent brain imaging
imaging
followed by
followed by
exchange
exchange
transfusion.
transfusion. So what they should specify whether investigation is required or what is required. Okay,
Yes.
but they have given both, so we are on the right track. Okay, so there has to be clarity in the question. Next,
A 24-year-old presents with hemoglobin 5.5 and fatigue and low reticulocyte count. So here the option will be, can I see the option,
yes,
sir?
yes.
Top up transfusions A.
Correct, correct. Top of transfusion.